Next, we have Dr. Shelby Sullivan, and it gives me great pleasure to introduce Dr. Sullivan, who is an associate professor of medicine at the University of Colorado and the director of the gastroenterology, metabolic, and bariatric program. Dr. Shelby Sullivan will be talking to us about some of the new and exciting development in endoscopic management of obesity. Dr. Sullivan, you got the
All
stage.
right. Thank you so much for the invitation. Can everybody see my slides okay?
Thank you. Fantastic.
Perfect. These are my disclosures. I have been involved in a number of these studies, and I also consult for a number of companies, both to help them with their lifestyle therapy protocols during their trials, but also to help them through the regulatory process with the FDA. So obesity is a really significant problem. We all know this, but I like this slide because it really puts it into perspective a little bit. So we have about 101 million Americans, US adults, that have a BMI of greater than 30, and about 24 million adults that have severe obesity, so obesity where they would qualify for bariatric surgery, essentially. Of those, about 207,000 primary bariatric surgeries were performed in the US in 2018, and only about 1 to 2% of patients are actually treated with pharmacotherapy or obesity medications. So that means that less than 5% of the population who has obesity is actually treated per year. So we really need to, as a gastroenterologist and endoscopist who are intimately involved with the GI tract, really need to help step in to help increase treatment of patients. And there's a number of therapies that have been developed and approved by the FDA for use for endoscopic treatment of obesity. There's the Orbera balloon, which was approved in 2015, the Aspire Cyst system, which was approved in June of 2016, the Obalon balloon system, which was approved in September of 2016, the Transpyloric shuttle, which was approved in 2019, has not yet been commercialized, and the Overstitch device, which has 510(k) approval for tissue approximation, and we use this to do both endoscopic sleeve gastroplasty and transoral outlet reduction, which we'll talk about in this presentation. Now, there was another balloon that was approved for use in the US. That was the Reshape Intragastric Dual Balloon. It no longer has FDA approval. It's not because there was anything wrong with the device itself. It got purchased by Apollo Endosurgery, and they elected to not continue the regulatory upkeep of that device. And so just simply by not keeping up with that regulatory paperwork, that no longer has FDA approval, but it was not for cause. We want to be specific on that. So the Orbera balloon is a single silicone balloon that is delivered transorally and is inflated under direct visualization with saline that is filled between 400 to 700 milliliters. On average, most people really fill these balloons between 550 and 650 milliliters. It's removed at 6 months. It's indicated for patients with a BMI of 30 to 40, and an absolute contraindication for placing these procedures is prior foregut surgery. The balloon is removed kind of in the reverse process of what it was when it was placed. There is endoscopically, you go down, you insert a catheter into the balloon, puncture the balloon, take out all of the fluid, and then grasp it with a 2-prong grasper and remove it through the esophagus. The Obalon balloon system is a swallowable balloon system. It has 3 capsules that are swallowed over the span of 6 to 8 weeks. Each capsule contains a balloon that is able to hold 250 milliliters of a nitrogen mixed gas. The device no longer requires fluoroscopic guidance or digital X-ray guidance for placement. It now uses a navigation system that is based off of electromagnetic properties. And then an dispenser that is no longer manual, it's now automatic. So you push a button and it does everything itself. And I'm going to show you a little video here. So the electromagnetic localization, essentially there's a sensor that's placed at the xiphoid process of the patient. There's a field generator that's behind the patient. And then there's a little magnet that's inside the catheter that attaches to the balloon capsule itself. And so you can see on this screen that you can see a schematic of an actual balloon being swallowed, or capsule being swallowed. And you can see it's currently in the midline, still in the esophagus. When it hits the stomach, it'll actually come off of that midline because it'll be going into the stomach. You'll see that it will turn, as it is right now, turning from a vertical position to a horizontal position. And then in a couple of seconds, you'll see that the patient will take a deep breath. As the diaphragm flattens out, the capsule will sink, there it goes, and then come back up. And that's how we know that it's actually in the stomach, so that we can inflate it safely. The removal is done endoscopically still at 6 months. This is what the balloons look like when they're actually in the stomach. You can see they take up quite a bit of space. This is also indicated for patients who have a BMI of 30 to 40. Absolute contraindication, again, prior foregut surgery. This puts the patient at increased risk for gastric perforation. And also for this balloon, because patients have to swallow it, another absolute contraindication would be failure to actually swallow the practice capsule that patients swallow when they're in clinic with me before they even come in for a procedure. In terms of comparison of the pivotal trial data, I am still including Reshape in here just to kind of make a couple of points, but again, Reshape is no longer approved in the US. Both the Reshape and Obalon balloon systems, though, were studied under a sham-controlled trial. And what we've discovered after doing these device studies for a while is that the sham-controlled studies, the effective sham, is actually to reduce the total weight loss that we see in the active arm. And you can see that for both the Obalon and the Reshape, the weight loss is about the same in the intention to treat analysis, so 6.6 and 6.8%. That's compared to 10.2% in the Orbera group. There is also a difference in serious adverse events in the gas-filled balloon versus the fluid-filled balloons. Fluid-filled balloons have more serious events that are associated with them. Most of those are related to accommodation, so nausea, vomiting, dehydration that require IV fluid hydration. A much lower occurrence of that occurring in the Obalon balloon system. In general, it has a better tolerability, a decreased need for treatment of nausea, vomiting, and dehydration. So this also demonstrates, again, the difference of when you know you have a device versus you don't know you have a device, specifically when we're talking about obesity and obesity treatment. So we can see in the blue bars what we had just showed you, which is the weight loss in the randomized controlled trial. Again, Reshape and Obalon were sham-controlled trials, whereas the Orbera balloon was open label. And the red bars are clinical case series, registry series in the US. And you can see that there's significantly more weight loss in both Reshape and Reshape and Obalon in their clinical open label series versus the randomized sham-controlled, and about the same amount of weight loss across the board for each one of the balloons. Orbera has also completed their post-market approval study. This just was recently published online, has not been published in print yet. They enrolled 284 subjects, and 258 subjects actually started the study. You can see that BMI, age, and sex range is very similar to what we saw in the actual pivotal trials. This is consistent with a lot of obesity treatment, is that predominantly it's women who are seeking treatment. Failed placement occurred in 8 patients, and there was early removals in 47 patients. But I think one of the things that is really impressive with this trial is that despite the fact that there were early removals, a number of those patients still continued and finished the trial. So they still had 234 patients that completed out to week 52. Their serious adverse event rate was 8.9%, so still similar to what we had seen in the pivotal trial. Again, most of those were related to nausea, vomiting, dehydration, leading to hospitalization. You can see with weight loss, there was 12.5% total body weight loss at 6 months and 8% total body weight loss at 12 months. So we still see that there is significant weight loss maintenance at 12 months. This is in comparison to something like weight loss medications, where we see almost all of the weight loss related to that medication coming back within 6 to 8 months. Weight loss maintenance is also seen in the Obalon balloon as well. So this is from the SMART trial, the pivotal trial in the US. And what we can see is that in patients who had any weight loss, which was the most of, or patients who actually completed 6 months, we see that there was 7.6% total body weight loss. And in those patients who were again seen at 12 months, that weight loss maintenance was about 90%. So again, very good weight loss maintenance with these balloons. One of the questions that I frequently get is, well, don't patients just regain all of their weight back as soon as the balloon comes out? And as it turns out, that's not actually the case. again, with both of these series, you see that there's significant weight loss maintenance that occurs through month 12. And even in series that looked at year 2 and year 5, there was still weight loss maintenance. Less weight loss maintenance at year 5, but still weight loss maintenance more than what you would get with lifestyle therapy alone. There are some other things to note, though, that weren't in the trials. So there have been a number of letters to physicians that have been published by the FDA, and these are in relation to events that have occurred in the US with these, either in the US or outside of the US, with these devices that were not reported in the pivotal trial. And so these include pancreatitis, hyperinflation, and deaths. And at the time of this update, there were 12 deaths, 7 of which were inside the US, and at least half of those deaths were related to gastric perforations. Possible that these could be related to ischemia, but at least one of them was in a patient who had prior foregut surgery and had a balloon placed. So again, we want to make sure that with these, especially with the fluid-filled balloons, if there's any symptoms that pop up after the balloon has been in for a period of time, you want to make sure that you're following up with that patient. The Aspire Assist system is another one of these therapies. It's similar in concept to a percutaneous endoscopic gastrostomy tube and placed with a pull technique. So you place it exactly like you would place a pull peg tube. And in fact, you cannibalize a pull peg kit and you just use the A tube instead of the tube that comes with the kit. Patients aspirate gastric contents 20 minutes after a meal 2 to 3 times a day, and it removes 25 to 30% of the calories consumed at that meal. And we determined that during the actual pilot study where we actually did an analysis of the gastric aspirate and had our bionutrition kitchen make these very carefully calorie counted meals. But that still only accounts for 50 to 80% of the weight loss. So patients have significant mealtime and behavior changes that reduce overall food intake. So I want to make this very clear. These patients are eating less with this device in than they were eating before. And one of the reasons for that is that in order for food to fit through, and hopefully you can see this, in order for food to fit through this tube, food particles have to be less than 5 millimeters because the diameter inside of the tube is 6 millimeters. So patients have to chew their food like they've never chewed before in order for food to reliably fit through the tube when they aspirate. The other thing is that food choices improve anecdotally. You can see that the tubes are clear. So again, we have the implanted components of the A tube and the skin port, and then we have the components that are only used during aspiration. Those include the connector that connects to the skin port, the patient line, the companion, the reservoir, and the drain tube. The reservoir is just used to flush the system. And the companion really just allows for one-way flow, either up or down, depending on if the lever is open or closed. But the drain tubes are clear, so patients can see what's coming out. And food that's not healthy, hamburgers, French fries, things like that, really don't look very appealing coming out, whereas the food that is healthier food choices really don't look that much different going out than they did coming in, and it really helps to reinforce positive food choices. And this is approved for a higher BMI category, so patients with a BMI of 35 to 55. There have been multiple studies that have been done. This graph looks at patients who have completed at least 1 year of therapy, and we have both the Pathway study, which is the multi-center randomized controlled trial in the US pilot study, the Swedish pilot study, a super obesity study with patients who had a BMI of greater than 55, the European registry, and a Swedish comparative study that compared aspiration therapy to gastric bypass. And what you can see is that at year 1, weight loss is between 14.2 and 21.5%. But if patients continue to aspirate, that weight loss is maintained. So even out at year 4, we have about 17 to 19% total body weight loss that is maintained in these patients. Again, even in this moderate to long-term time point. There were several non-serious adverse events that occurred in the pivotal trial. This is the largest randomized controlled trial with the most careful analysis of adverse events. But I think this really is consistent with what we see in clinical practice. And a lot of patients develop peristromal granulation tissue. This is very similar to PEG tubes as well. In years 2 through year 4, peristomal granulation tissue and peristomal irritation were the most common adverse events compared to peristomal irritation and pain after placement in the first year after treatment. In terms of serious adverse events, there were 5 serious adverse events that occurred in 4 subjects, all resolved without sequela in the first year. In years 2 through 4, there were 2 serious adverse events, and there were 12 gastrocutaneous fistula that required additional therapy. So in general, as we all know, when you have a chronic gastrocutaneous fistula, it does sometimes takes additional endoscopic therapy in order to get those tracts to close. And there was no evidence of worsened eating patterns. That's another question that people frequently have with this therapy. Endoscopic sleeve gastroplasty. This is a therapy that is performed using the Apollo overstitch. There has not been an FDA trial of this published to this point, but there is a trial that's currently ongoing. Now, again, this is used with a device, the overstitch device, that has 510(k) approval for tissue approximation in the GI tract. And this is an animation of suturing in the stomach. And we usually use argon plasma coagulation to make some marks in the stomach first. And then we place make our bites and place our suture. It does require general anesthesia. I also usually consider total intravenous anesthesia with propofol. It helps to reduce nausea. We do DVT prophylaxis because there have been reports, at least one report, of a pulmonary embolus and deep venous thrombosis after one of these procedures. And I also use IV antibiotics during the procedure. Post-procedural considerations are really to suppress vomiting. We don't want patients to vomit so that they break any of those sutures. So I have a number of different medications, a whole cocktail that we give in order to control nausea. Pain is usually less of a problem, but we do give patients treatment of that if needed. So I just want to, whoops, let me go back. Sorry about that. So I just want to go back to this slide here, and in that slide that you saw, there was kind of a Z pattern with suturing. We really mostly now use a U shape. I take 8 to 10 bites per U shape in the stomach, going from the distal gastric body to the proximal gastric body, and then I usually do a second reinforcing line that I do typically either interrupted sutures or 2 or 3 bites per suture. This is an image of one of my more recent endoscopic sleeve gastroplasties, and also information about a meta-analysis. So this is both data from inside the US and outside of the US that included 1,772 patients. We had weight loss of 16.5% at 12 months and 17.2% at 18 to 24 months. You can see here that there were 2.2% adverse events in this series, nausea requiring hospitalization in 1%, bleeding in 0.56%, a perigastric leak in essentially 0.5%, and again, that one episode of pulmonary embolism. We have 5-year data out of Cornell. This was a series of 203 consecutive patients. This was presented at Digestive Disease Week in 2019. These patients had about an 89% follow-up rate at 5 years. Some of them were on medications, but a quarter of them were weight stable on weight loss medications prior to the procedure. So it just highlights the fact that, combination therapy is actually really beneficial for these patients. And in many cases, using more than one modality, medications plus endoscopic therapies, really helps us get more weight loss. And in this series, there was about 15% total body weight loss at 5 years. All right, last topic. This is secondary treatment of obesity, so weight regain after gastric bypass. It's likely multifactorial, and it occurs in about 25 to 30% of patients. And it really is closely associated with the diameter of the gastrojejunostomy. This was a study that was published in 2011 in patients who were undergoing upper endoscopy. And what they found in a multivariate analysis is that the gastrojejunostomy diameter was a significant risk factor for weight regain and one of the biggest predictors of weight regain. And you can see the graph here on the graph here that demonstrates the percent weight regain as it relates to GJ stoma diameter. So one of the therapies that we do for this is transoral outlet reduction. And I'm sorry for the little spelling error there. So this is endoscopic suturing using the Apollo overstitch device at this point. There are other suturing devices, but we don't really have them available in the US. And what we're doing is reducing the diameter of the gastrojejunostomy. There are different types of suturing that you can see here. There's interrupted sutures, there is a purse string suture, and there are running sutures. The independent predictors of percent excess weight loss in a meta-analysis that was published in 2018 was reducing the stoma by 85% or more, using the purse string technique, and the interval from time of Roux-en-Y gastric bypass to the TOR procedure. There's also been, even prior to that, a randomized sham-controlled trial called the Restore trial with a previous generation suturing device that was not full thickness. And what they demonstrated in this study was that there was significant difference in weight loss between the active arm and the control arm, again, in this sham-controlled study. It's important to note that both of the groups were on a liquid diet for that first 6 weeks, so they both lost weight as a result of that. And once they came off of that liquid diet, patients who were in the sham arm quickly regained weight, whereas patients in the active arm maintained their weight loss. There's also 5-year data on the TOR procedure as well. This is in 331 patients who underwent 342 procedures. Argon plasma coagulation was performed in all of these patients prior to their suturing. There's a variety of different suturing patterns, but most of them were using the purse string. Final gastrojejunectomy anastomosis was 8.4. There was no serious adverse events, but a 3.2% moderate adverse events. And in about 20% of patients, there was adjunctive use of medications, and 1.2% of patients went to surgery. But you can see that weight loss maintenance of about 9% total body weight was maintained at about 5 years. This is really impressive in patients who have regained weight after gastric bypass, because in general, many of those patients just continue to gain weight. So to not only stop their weight regain, but to reverse it and keep it reversed for multiple years is really important. Just a very quick case presentation in a 54-year-old patient who had weight regain and had regained 48% of her weight, not successful with lifestyle therapy or phentermine. We started her on topiramate. That also didn't work. She had a large pouch and a large anastomosis. We did argon plasma coagulation. We did a purse string suture in the anastomosis, and then also did a modified sleeve in the pouch because it was so long. And she, at 6 months, had lost 23% total body weight. So in conclusion, endoscopic gastric bariatric therapies have higher weight loss than medications, but less than bariatric surgery. Primary endoscopic bariatric therapies have less complications than bariatric surgery, and there's multiple different kinds, and they vary in complexity, weight loss, and complications. And then endoscopic gastric bypass revision is safe and effective. And that's it.
Thank you very much, Selby. Great talk as usual. And clearly you could tell the passion. Thank you very much again.